We're going to do a quick recap on Edna Gray. She's a 67-year-old woman who has chronic right knee pain. She's had a previous history of left ACL rupture and have had surgery on it. She has high cholesterol that is being medicated with Lipitor. She has bowel cancer and irritable bowel syndrome, and she has previously experienced depression. She has mentioned that she would like to use TENS again, and that she generally feels looser after a shower in the morning. Edna has general swelling in her right knee and her functional movement is quite poor. She also has restricted range of motion of her left knee and left ankle, as written on the slide. She also has trouble with functional movements such as straight leg raise, squat, and single leg squat. Our goal for Edna is to relieve pain and educate her about the perception of pain. We're going to investigate what pathology is causing pain through physical examination or imaging modalities. We're going to discuss with Edna on an agreed intervention for patient-centered care. Based off her history, the application of thermal therapy, heat, and TENS will be used to manage pain and return Edna back to what she loves doing, and that is ballroom dancing and spending time with her grandchildren. The International Association Study of Pain reconceptualized pain and defined it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The perception of pain is a summation of biological, psychological, and social factors that is called the biopsychosocial framework. Nociception is the neural processing of noxious stimuli through the peripheral nervous system and the central nervous system. Pain typically serves as an adaptive role to protect the organism from harm. When the perception of pain is abnormal, you will experience a heightened perception of pain called allodynia, meaning pain from a non-painful stimuli, or hyperalgesia, heightened pain from a painful stimuli. There is also decreased inhibition called disinhibition. It is important to note that the experience of pain should be respected, and because an organism is unable to verbally express pain, it does not negate the experience of pain. In 1998, Keefe introduced the mature organism model, highlighting the perception of pain is a summation of tissue sampling of what is going on in the body through afferent and sensory pathways. Environmental sampling is what's going on in the external environment, and self-sampling is from past experiences, beliefs, knowledge, and culture to give value to the pain experience and influence the physiological and behavioral output in survival and recovery. The biopsychosocial model considers three factors influencing the experience of pain: the biomedical model, the psychological model, and social model. This concept has led to a multimodal framework for the management of pain. So here we have the biomedical model of pain with neuroscience. The first order neuron is the stimulation of nociceptors by noxious stimuli detecting thermal, mechanical, and chemical following tissue damage. Propagation of action potential from said nociceptors to spinal cord. Synapsing with a second order neuron decapitates the information to the contralateral side of the dorsal horn of the spinal cord, traveling through the spinothalamic pathway to the thalamus. The third order neuron from thalamus to the somatosensory cortex. Modulation of this afferent pain signals by descending pathways. There is projection to various central nervous system centers involved in the processing of pain. Edna is experiencing both chronic pain throughout the day and sharp pain with particular movement. This is explained by the varying fiber types. There is A delta fibers with thin myelination that helps transmit information faster to the central nervous system and is responsible for well-localized sharp pain, arriving first. This is responsible for Edna's sharp pain. There is also C fibers that are unmyelinated that transmit information slower, causing dull ache, diffuse pain that is perceived second. This is responsible for Edna's chronic pain. The intervention for Edna, we're going to use TENS. This is short for Transcutaneous Electrical Nerve Stimulation. The idea is electrical stimulation activates the non-noxious afferent fibers, which activates the pain-inhibiting interneuron in the spinal cord and reduces the perceived pain output. Electrical stimulation activates the alpha-beta fibers, inhibiting the noxious alpha-delta and C fibers. This closes the gate and prevents pain signals passing through the brain and is called the pain gate theory. We will also use heat thermal therapy to help Edna with circulation of edema around her knee. This facilitates knee range of motion, and the heat will create a thermal analgesic effect via the parasympathetic system and will also provide pain relief through the pain gate theory. Both these applications will provide short-term pain relief for Edna and reduce time spent with disability and give her capacity to see her grandchildren, do some gardening, and participate in ballroom dancing. It is important to discuss with Edna and explore long-term avenues and interventions as well. And these are the references we've used for the PowerPoint today.